بسم الله الرحمن الرحيم. الحمد لله وحده والصلاة والسلام على من لا نبي بعده. أما بعد, السلام عليكم ورحمة الله وبركاته. I am Dr. Zakaria Gnoon, consultant in diagnostic radiology, currently practicing in Saudi Arabia. Today we'll delve into the fascinating interconnections between raised intracranial pressure, papilledema, optic nerve sheath distension, and optic nerve atrophy. We will explore how these findings form a spectrum of disease, their pathogenesis, how they relate to each other, and of course the MRI findings of each one. We begin with raised intracranial pressure, which, like its name suggests, refers to an increased pressure within the skull. Its main MRI findings are a sagging brain, slit-like ventricle, an enlarged Meckel's cave, an empty cella, and also a venous sinus stenosis. Then, along this spectrum of increasing severity, we will identify papilledema, which is defined as swelling of the optic nerve head, which is the part of the optic nerve visible on endoscopic exam. It's a classic sign of increased intracranial pressure, but not always specific. The MRI will show posterior globe flattening, protrusion of the optic papilla, and tortuosity of the optic nerve. Further pressure will cause optic nerve sheath distension, which is the enlargement of the fluid-filled space surrounding the optic nerve. We can easily measure it on MRI by assessing the optic nerve sheath diameter, ONSD. So we calculate this diameter 3 mm behind the ocular globe on MRI, and the threshold of greater than 5.28 mm is considered suspicious for raised intracranial pressure. Then, finally, chronic papilledema will lead to damaging of the nerve fibers and their degeneration, resulting in optic nerve atrophy and even vision loss. This occurs, like we said, in cases of chronic raised intracranial pressure, and we can assess optic nerve atrophy on MRI by calculating the optic nerve area at halfway point between the optic disc and the orbital apex. A measurement below 4 mm square suggests optic nerve atrophy.